Good evening. Recognizing that there are still a few empty seats around there because they're still on Telegraph and 275 and 75 and 96 and all those other numbered roads that we won't mention right now. Nonetheless, we'll go ahead and get started. I'd like to welcome you all here tonight, and I think basically I'm in charge of doing a few housekeeping items, and then I'm going to turn it over to Dr. McClellan, who's going to introduce the rest of the program for us. First of all, I want to thank Beaumont Hospital for supporting this meeting with, you can see the little clickers that we received, and if you've noticed, the sound system and the videography that's going on, so this will be available later on, is all through the generosity of Beaumont. So we want to thank you guys. I'm assuming that there's more than Dr. Flanders here. I just haven't seen, maybe they're stuck on Telegraph too, for all I know. Secondly, CMEs. You are eligible to receive 2 CME credits for tonight's meeting. Remember, though, to do that, you have to fill out the evaluations that are in your packet and turn them in as you leave tonight. So please do that at the end of the session tonight. Now, these little keypads, you'll see signs on the tables and you'll see signs on this. They're all numbered. We know who you are because you had to sign them out. If you don't turn them back in, we will come to get you, and besides that, there's a $50 charge for it. So please don't forget to turn these in when you leave tonight. They are important. You will have some fun with these later on in the evening, and I think we'll all learn something for it. So just make sure that you remember to turn them in when the meeting's over. And finally, there will be a question and answer session after the speakers' presentations during a panel discussion. And we'd ask you that you refrain from asking your questions until then, because we'll be glad to submit them to our panel, and you can stand up and ask all the questions you want once that's over. So I think that's all there is for housekeeping. And with that, once again, I'd say welcome to our third quarter PAC meeting, and I turn you over to Dr. Steve McClellan, who's the program director for tonight's session. Steve?
All right, it's going to be pretty fast-paced today, so we want to keep moving. But we did want to introduce you guys to the interactive touchpads. And again, we want to thank Beaumont for helping out with that. Michael Holland with their CME and tech department has been superb as always to work with. Do you want to come up, Mike, and kind of show how this works? Because this is, I've never run one myself. So Mike will give you the instructions.
Hello, everybody. Everybody should have a keypad in front of them. When a polling slide is presented on the screen, you're going to see several options. Each option will correspond to one of the buttons on your keypad. 1, 2, 3, 4, A, B, C, D, whatever corresponds to that you would like to select, just select that button. If for some reason you should change your mind, you can click the button again. It will erase your previous answer and put in your new answer. So, enjoy.
So this is our first question, just to kind of get used to it and kind of get a little demographics of who's here today for our panel. How would you best describe your practice? And we're always never sure if OBGYNs are primary care specialists either, so we just put them as their own category. I know at least Mike Genord's here. And those are the responses. Just forward that, Mike. Okay, 79% primary care, 17% specialists, and 5% OBGYNs. Not sure. Okay, for the PCPs only, my practice is currently PCMH certified or designated by any of those organizations. Go ahead and we're going to have one for the specialist too. Whoops. Did I go to that? Okay. 82% are on board with PCMH certification or designation. And one more. Well, the most important determinant of healthcare quality is efficient and effective care, patient-centeredness and satisfaction, safety, equality and access to all healthcare services for all, and timeliness of care. All right. Efficient and effective care, interesting. Patient-centeredness is down a little bit. And nobody thought that timeliness of care was important. I agree with that too. Okay, with that, we're going to go ahead and introduce our first speaker. Our first speaker is Dr. David Spahlinger. I love looking at these CVs because they're very interesting. He grew up in Ohio and then went to Ohio State University and has been at University of Michigan for most all of his life. So go figure that one out. It's going to be like a U of M home week here when I started to read everyone's CV. But David's got a very lengthy CV, and I don't think I could have gotten mine half that long if I even put the Glee Club and Student Senate in high school on mine. But he's got a lot of interesting background and a lot of presentations. But most importantly, for the last about 8 years, he's been the Senior Associate Dean for Clinical Affairs at the University of Michigan Medical School. And of real importance and to his qualifications for speaking here, he's the Senior Associate Director for the Ambulatory Care Services at the University of Michigan and is in charge of the U of M Family Practice Group, which is about 1,700 physicians. So I think anyone who can get that many people together and keep their job for 8 years deserves the opportunity to speak to us. So come on up, David.
So, I guess this is working. Can you hear me? So I guess. So when Dr. McClellan asked me to talk, he asked me to talk about the history of quality. And I'm a history buff. I like history, and but as I started reading about the history, just went back and read a couple of the earlier articles, I changed my talk to the evolving view of quality. And some of you, I think, if you're anything like my group, I run into physicians who I tell them about quality scores, and they say, well, that's not quality. And what we get measured on now is much different than at least what I felt was quality when I trained. It was really about whether I made the right diagnosis, whether I prescribed the right treatment, but anymore it's evolved to a much broader definition. And just give you a little bit of background. So I went back and read Donna Bedian's first paper in 1988, and you all have seen this, which is he pointed out at that time that quality could be defined as both the structural aspects of a setting that lead to better outcomes, the process of care, and then the outcomes of care. But what you don't maybe remember is in that article there was another pretty good discussion about what really constitutes quality and how in order to measure it, we have to define what we're measuring. And at that time, the performance of practitioners, he defined it into two different areas. One was the technical competence of physicians, which most of us believe, and most of us have grown up thinking that that's the most important part. The other thing that I found interesting back in 1988, the second part of physicians or performance of practitioners was interpersonal skills. Though he readily admitted there was at that time very little to measure that, but he felt that interpersonal skills were really was the implementation part of a physician in order to engage the patient in their disease, engage the patient in taking some responsibility, and it felt that it was the art part of medicine that made physicians effective in treating disease. And of course now we do have some patient satisfaction. Whether that really gets to interpersonal skills, we could talk about. The other interesting thing that I think I've forgotten, and maybe even I think a lot of payers have forgotten, is that part of the measurement of quality, there is a contribution of patients. We all know this because some patients are engaged and some patients aren't engaged. He described this as a significant part of quality, that the patient can make a contribution, as well as the patient's family, in making sure that the outcomes of healthcare are better. And the other thing he described was the contribution of health systems. We all know that there are systems, whether that's electronic record, whether that's sharing of information, whether that's how we interact with each other, are important contribution to the quality that's delivered. And then finally, how broadly we want to define health, as we more and more are required to engage the patient in their personal to be sensitive to what their wishes are, their cultural wishes, their shared decision making. Do we define it based on what's the right decision, or do we base it on the patient's preferences? Do we get to exclude patients who have preferences that are at odds with what we're measuring? Most of the time we don't get to do that, but that is something that was in the original article in 1988, that is something that needs to be considered in quality. So most of you then are more familiar with the Institute of Medicine definition of quality, which is to the extent in which health services are provided to individuals and populations and improve desired health outcomes. This is in crossing the quality chasm. And in that, they define quality in 6 aims for improvement. They didn't define it as, first of all, safe. This is the question you answered just a few minutes ago. That is avoiding injury to patients and making sure that our health system doesn't have untoward effects. Effective, that is, we provide the best, provide service based on the best scientific knowledge. Now that's not always easy, because what we are given in scientific knowledge, we find it sometimes doesn't always work in practice. How many of you remember the Rouse trial? Anybody heard of the Rouse trial? I only know it from U of M because it was done at U of M, which was to use spironolactone for heart failure. How many of you ever have seen the paper in the New England Journal 3 years later about the deaths that occurred in Ontario because of the implementation of that quality, that high quality study? So the study was good. There was a 30% reduction in heart failure. The problem is, between 1998 and in early 2000, the advent of, we also knew that beta blockers were important in treatment of heart failure, and beta blockers have an impact on the distal tubule and prevent excretion of potassium. And so what happened in Ontario, as they rightly implemented the right treatment based on the most recent data, is they saw a rash of hyperkalemic deaths with the implementation. So it's not always as simple. We all know that beta blockers were supposed to be given before every surgery till we started having complications associated with it. So sometimes the scientific knowledge is based on a narrow population, and that can't be broadly implemented. So patient-centered, I talked a little bit about this, being respectful and responsible to individual preferences and needs of the patient. Timely, this is something I have a lot of difficulty with trying to work with our faculty. I readily admit that at U of M, we have 120,000 new patients every year that wait more than 4 weeks to see a physician. Now, that's a dramatic improvement, actually, but but it is hard to get, it's hard to engage physicians in saying that's important. The way I've tried to do it is to say that would you want your mother to wait that long, and also that we want to reduce the time frame from presenting symptoms to resolution of the symptoms or treatment of the disease. Time or efficiency, avoiding waste, and equitable is that we treat everybody in an equal fashion and are not irrespective of race, class, gender, other things, which we all try to do, I think, but this is more of a problem, I think, related to inadequate insurance coverage. So the evolving, I'm going to step back and talk about chronic disease because I think the increase in chronic disease has now affected how we define quality and how we're being measured. So this is a recent, is an article from 2007 talking about the rise in chronic disease in the U.S. And you can see that cancer prevalence is supposed to increase by 62% by 2023. And diabetes, hypertension, pulmonary conditions, heart disease, mental disorders, and stroke. You can see the increase in dollars. So certainly we're going to have a significant pressure on how we're going to try and change these curves, if you will, bend the cost curve. Otherwise, we're headed for a significant cost escalation over the next 10, 15 years. And in order to try and do this, as I said, we not only need to implement some of the studies that we find related to medication, but this was an article that looked at processes of care or structural elements within your practice that make a difference in lower hospitalization. So this is something, I think as a physician, I would say we're sometimes not attuned to. You would think this is more the organization and how we organize the office, but these things, frequent in-person contact between the care manager and a patient within 24 hours of discharge, frequent contact between the physician and the care manager relays all the key information to the physician. Your patient education programs that you have are effective and evidence-based, and they have reliable information about the patient's medications, and there's timely notification of the patient's hospitalization and communication with the hospital staff and even visits in the hospital. That's something that we don't think about in traditional practice. I know that from my perspective that we haven't done. Finally, if you look at the number of patients with chronic disease, patient has one chronic disease, sees on average 4 physicians a year, 5 chronic conditions, 14 different physicians per year, and patients that have more than 5 chronic conditions account for 76% of Medicare costs. And it's estimated that the over 85 population will quadruple by 2050, and 47% of patients in the U.S., or 133 million, who have chronic disease have more than one. And if you were to provide the kind of care I just said in the last slide, that is, you're providing just management, not seeing patients, and had to do that yourself, that's estimated that would take 10.6 of your hours a day. So there needs to be a change in the way we deliver care and how we have support in order to deliver the kind of quality that we want or we're being held accountable for. So the issue is with the rise of chronic disease, there's been a shift from what I used to think of and what way I practice, which is more acute episodic care, to chronic management of patients with multiple different conditions. And that management of chronic conditions means I need to coordinate with as many as 14 physicians on a patient if they have 5 conditions or more. And that now becomes a multidisciplinary process, and it becomes more a team sport. And that team, from my perspective, is the medical group. It is the United Physicians, it is the Beaumont Medical Group, it is the U of M Medical Group, and the physicians working together with these complex patients in order to deliver the best care possible. There's a lot of talk about integration. My perspective is unless you integrate the physicians, integrating them just within the hospital doesn't really deal with the issue, which is a lot of these patients don't end up in the hospital. It's really how do you communicate among each other, and how do you work to try and deliver better outcomes for these patients. So the quality outcomes then become dependent on not only clinician technical expertise and patient engagement, but the communication and collaboration across the members, across the specialties of your physician organization, and then engagement of all components of the health system, whether that's the hospital, the home care, and nursing facilities, in order to deliver better care. But the first step is how you come together as a group to deliver better care and collaborate. That's all I had. Go this way.
Thank you very much, Dr. Spahlinger. We're going to have more input from all the speakers in a few minutes with a panel discussion that will be led by our president, Mike Williams, and then you'll have a chance to ask some questions. But we want to hear from you guys next. We have a few more questions. Patient satisfaction with my services as measured through patient satisfaction surveys, and this is kind of a hot button for a lot of people, is helpful to me and my practice. Strongly agree is 1, and then down to 5, strongly disagree. This is something that's going to be coming, and we bring it up. It's part of patient-centered medical home, which we have not done very much with as an organization, and are looking into doing more. And the payers are looking into this in a big way. Kind of makes some of the hair on the back of our necks bristle a little bit, I'm sure. Okay, the responses. More positive than negative, so that's encouraging. I'm not sure how I feel about it half the time either. As a specialist, this is just for specialists, I have the necessary clinical information when I am seeing a patient for the first time in consultation from a PCP. This is in the outpatient setting, so don't think about if you're seeing the patient in the hospital, it would be in your office as a specialist. Okay. Strongly disagree. That's very telling. Can we not make these public as an organization? This is something that we may need to look into. And I feel confident when seeing patients in a handoff from specialist care, nursing homes, and the hospital that I have the necessary information to provide a smooth transition. And this would be for specialists and for PCPs, all attendees. Strongly agree, number 1, down to strongly disagree.